professor, physician, epidemiologist. I am Dr. Sri Banerjee. Hello, I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University with a joint faculty position at Ross University School of Medicine. And lately we have been discussing about the topic area of childhood obesity, and I thought it would be interesting to look at a critique. And whenever I see the word critique, I oftentimes want to look into that paper a little bit more because that means that something, a policy level or some sort of recommendation is being challenged. And that is always interesting. So this is specifically a critique of the English national policy from a social determinants of health perspective, using a realistic and problem representation approach, the Childhood Obesity, a Plan for Action 2016, 2018, 2019. The title really doesn't say much, but I'm going to tell you this from the start. This is looking more at the social factors, some of the upstream factors that lead to childhood obesity, rather than focusing on individual behavior level modifications like restricting diet. So for instance, I've written, along with collaborators, on food insecurity. So not having regular access to nutritional food. This is something that is a challenge. And so when you don't have access to regular food, then that can lead to obesity even. Because then you're relying on starchy foods, which then increases the likelihood of obesity, and then leads to other types of comorbidities such as diabetes, and even early non-alcoholic fatty liver disease, so liver damage. So what is the criticism? So again, the criticism is this. We are looking at this from an individual level, when this should be understood from a population perspective. So upstream policies, upstream factors, these are what need to be the focus. So let's go back and revisit the Marmot Review. And this was critical in the development of the social determinants of health perspective. So for those of you, if this is the first time you're looking at the social determinants of health, this argues that health is closely linked to the conditions in which people are born, grow, live, work, and age, and inequities in power, money, and resources, the social determinants of health. So health policy has been critiqued for neglecting these structural forces and just looking at of neglecting causal factors that produce the social and economic inequalities and health inequalities, and just looking at the behavioral aspects and how these inequalities are being sustained continuously, is also a very serious question to be asking. So if you're thinking about why there is often little mention of these aspects, it's because understanding socioeconomic status, even food insecurity education level, and studying these things on a mass scale, on a population level, is challenging. It takes a lot of insight to be able to conduct this unique type of research. And so you don't have too many studies like this at a population level. But at the same time, food bank use has increased, which means food insecurity during the pandemic increased by 74%, and this is in the UK. But what is interesting from this the findings are that there's a definition problem in understanding childhood obesity. Um, is it calories consumed versus energy expended? So, are we looking at calorie intake? How do you define it? So, the effects of problem framing. So, if we're using this as a burden narrative, then that places no locus of control over how resources are distributed and budgets allocated within the health systems. So individuals really don't have as much control over resources and monetary allocations. So it's important to understand that difficult decisions in public health and public health investment, while resources are scarce, makes preference swing towards the treatment of victims in quotations, rather than doing preventative measures. So it's easier in the short term to be patching up quick fixes rather than investment in long-term prevention activities. But in order to invest in these long-term activities, we really need to focus our attention on what these long-term initiatives should be and may be in order to improve better outcomes. Blame narratives, they don't work. Blaming the child, blaming the parents, blaming the physician doesn't work. Additionally, there's stigma attached. Bullying, stigmatization, low self esteem. And oftentimes, the reason I say individual blame doesn't go very far is because oftentimes it's the metabolism of the child may be due to medication side effects that they may be taking, maybe early usage of antidepressants, or for whatever reason, other disorders might lead to weight gain. So there's a lot of things that surround on an intervention level, and a lot of other diseases that can lead to childhood obesity as well, that are more a reflection of socioeconomic status than anything else. So the policy has to take into consideration health inequalities. And so the prevalence of obesity of children aged 5 years, looking at this suggests helping to improve the health of our children and give future generations the best possible start in life. That is the goal. And so if we address these inequalities and understand like food insecurity, this is not something that leads to good health. This will lead to poor health. So food insecurity is discussed, physical activity, but then again, if the neighborhood, there's violence within the neighborhood, if there's firearm usage, then physical activity will be hindered. And so the social determinants of health that um, uh, are surrounding that, the social arrangements, as is used, the terminology used in this paper, will then not facilitate usage of the outdoors. So it has to physical activity even within the schools, even similar consideration should be taken into account. So in conclusion, when you're thinking about social determinants of health and structural inequalities, you want to be thinking about the five domains, specifically the five domains, but more generally, thinking about food security, poverty, and environment. And what is interesting, and I'm going to too many, is that there's a lot of nutritional programs to help out, interventional level programs for instance, WIC. And this is for income ineligibility less than or equal to 185% of federal poverty levels. And this is a pretty up to date. It's a bit dated, but this nevertheless it's a comprehensive list. So SNAP program, National School Lunch, National School Breakfast Program, these are still available. I know personally. Child and Adult Care Food Program, and then Summer Food Service Program. These are very beneficial for low-income families and individuals that may have families, um, and this can mitigate food insecurity. And so again, these are upstream factors that can be really used to understand some of these. Um, so the final portion of this that I wanted to talk about quickly is this 5-page document about produce prescriptions, food pharmacies, and the potential effect on food choice. And this talks about the produce prescription coupons, and these are monetary incentives, and I call them coupons, but they're monetary incentives which are similar to prescription programs, which promote consumption of fruit and vegetable. And believe me when I say this, fruit and vegetable consumption is underemphasized and needs to be emphasized for every child within the United States. A balanced diet is very important. So physicians screen for and identify appropriate patients and write them prescriptions for consumption of nutrient-rich foods. Local farmers markets, grocery stores, community-supported agriculture initiatives, these are areas that you should focus on. And because these are local farmers that are not making as much money, and so if you give them if you promote them, then actually it builds the community and gives and you're actually giving back to the community. So it pays in many different ways. Looking at what a prescription serves, well, it's two important purposes. Provides a recommendation to the patient, so it's an official sort of little paper, but it also authorizes a patient to be providing a treatment. So it's in a way a more official document. Subsidies range from coupons that save $5 per week on fruits and vegetables to completely free of charge. And there's food pharmacies to improve access to healthy food. So I like this, and this is by Guy Singer, Fresh Food Pharmacy. And that's the name of the program. But I like this short article in American Journal of Lifestyle Medicine because this is a structure that not all journals accept. But I've gone through quite a few aspects of understanding the different availability of obesity. Well, first of all, the public health issue of childhood obesity, a social determinants of health perspective, which de-emphasizes individual responsibility and blame, and more so emphasizes the structural and social determinants which caused the individual or families to get to the place where they were. And then looking for interventions, not necessarily that target childhood obesity, but again, are looking at addressing upstream factors like food insecurity. And if you address those instead of patching up damage later, then in the long run, the investment, monetary investment, is not as much. And then finally, we visit some of these specific programs and look at how food can be used literally as medicine. So I hope that this has provided you with many different perspectives in understanding childhood obesity. Thank you.